morning. I'm Dr. Christina Cruz, and I'm the primary author for our study that examines opiate prescribing habits and how they have changed in response to the national push to reduce opiate deaths in the United States. This poster details our follow-up data from our presentation at NAPCRG in 2019. This study included 168 patients with a mean age of 57, standard deviation of 15 years. After exclusion, our final N was 153 patients. Patients who were excluded from our original sample for analysis were not prescribed a controlled substance at the time of urine drug screen testing, for a total of 15 samples. The majority, 65%, of patients were female, 42% were African American, 54% were Caucasian, and 4% were of other ethnicities. 12% of urine drug screens were ordered for benzodiazepine use, 54% ordered for opiate use, 16% for a combination of benzodiazepines and opiates, and 15% for other indications. Controlled substance agreements were on file for 49% of the total group, a decrease of 7% from the previous year. For millimorphine equivalents, or MMEs, greater than 30, a urine drug screen every 90 days was appropriately done for 48% of the group, with an N of 56 patients, a mean MME of 76, and a standard deviation of 64 MMEs. This was an increase from 40% with an N of 30, a mean of 82 MMEs, and a standard deviation of 91 MMEs the year prior. In Figure A, we examined the ordering habits of our resident physicians, stratified by PGY year to delineate what percentage of resident physicians had ordered a single urine drug screen during our study period. The data shows a surprising conclusion. The PGY2 residents actually ordered more drug screens than the PGY3 residents, with our intern class ranking the lowest. The rate actually dropped from 2018 to 2019 for the PGY3 class as well. The reasons the rates dropped for that PGY3 class were an initiative by our clinic to refer patients with high MME requirements to outside pain management specialists, as well as the graduating third-year classes patients, reestablishing care with the 2019 PGY2 class for patient continuity. Figure B shows the mean MME for the total population, which was 47 with a standard deviation of 54. Our population data was stratified by either greater than or less than 30 millimorphine equivalents, with an additional stratification group that included those patients with greater than 30 millimorphine equivalents that also had a urine drug screen within the 90-day period as required by law. Stratification of millimorphine equivalents showed that our total population data mean was skewed due to the high millimorphine equivalent individuals. When the high millimorphine equivalent individuals, or 1/3 of our total study population, were removed, our mean MME dropped to 16 with a standard deviation of 5. Figure C shows the change in prescribing habits between 2018 and 2019. The data here shows better interpretation of urine drug screens, as more prescriptions were given for appropriate urine drug screen results. Confounders that cause the number of prescriptions given out for inappropriate urine drug screens include marijuana use and patients who did not take their medication the day prior to urine drug screen administration. In conclusion, the results of this study show that educational intervention is associated with increased urine drug screen reporting, both within the suggested time interval by law and the total number of patients screened. Appropriate prescribing also increased. In order to increase compliance, the barriers that remain include available physician-patient slots for controlled substance appointments and automation of the EMR to prompt patient compliance with keeping their appointments as scheduled. I hope you've enjoyed our poster. If you are looking for any opportunities to join our study or create a similar approach for process improvement at your institution, feel free to reach out to me at kcruz@augusta.edu. Thank you and have a great day.